I hereby open this academic ceremony in which Mohamed Kassem will defend the academic thesis Intraplaque Hemorrhage on carotid MRI in stroke patients on the road towards clinical application. May I invite you to present a summary of your research and the conclusions of your thesis.
Thank you. Dear Prorector, dear opponents, dear promoters, dear colleagues, friends, and family present here and those attending the live stream. For the next 15 minutes, I will provide a concise overview of my thesis entitled Intraplaque Hemorrhage and Carotid MRI in Stroke Patients on the Road Towards Clinical Application. First, I would like to explain two features of the cover. You can see here this area, this colorful area here in the brain, which refers to the ischemic stroke. Ischemic stroke is a medical condition where the blood supply to a part of the brain is reduced or blocked. And here, the carotid artery, which is a major blood vessel in the neck that supplies blood to the brain. Atherosclerosis is a medical condition characterized by the buildup of fatty deposits, cholesterol, and other substances on the inner walls of arteries. This buildup forms something called atherosclerotic plaque. You can see it here. When this occurs in the carotid arteries, it can lead to a condition known carotid stenosis or carotid narrowing. Carotid narrowing means the track of the blood is narrowed, as you can see here. Carotid plaque can rupture due to a combination of local factors and systemic factors. Atherosclerotic plaque in the carotid arteries are responsible for 15 to 20% of ischemic stroke. Typically, our approach to treating these patients depends on the symptoms and determining the extent of carotid narrowing. This often includes implementing lifestyle modification and medical treatment. Additionally, surgical option may be considered to reopen the artery, either by removing the plaque or by inserting a stent. Based on the results from two large randomized controlled trials, more than 20 years ago, reopening the carotid artery in cases of 70 to 99% narrowing can prevent 1 stroke out of 6. So for those with 90 to 69%, we need to perform the surgery to 22 patients in order to prevent 1 stroke. However, for patients with less than 50% narrowing, there is no additional benefit from these procedures. Now, if we look to these two arteries, if we want to treat those two arteries, we should treat them same because they do have same degree of narrowing. However, in the microscope, we can visualize different features that can differentiate between stable and vulnerable plaque. These features, such as thick fibrous cap in the stable plaque, where in the vulnerable plaque, we can see thin or ruptured fibrous cap. Also, there is intraplaque hemorrhage in the vulnerable plaque and large lipid pool. However, if we want to do the microscopic examination, we need to remove the plaque, which needs surgery. Therefore, looking for non-invasive imaging to visualize these features is very important. MRI is one of them. MRI is excellent imaging modality for assessing these features non-invasively. As you can see here, we can see hemorrhage and other features, and that need multiple images in order to visualize these features. However, these conventional MR images has a few limitations, such as long scan time, patient movement between scans, which leads to misalignment between images, and limited slice resolution in the 2D images. Intraplaque hemorrhage is very important risk factor that can predict stroke. In many MR research, it has been shown that the presence of intraplaque hemorrhage on MRI increased the risk for stroke by 10-fold. Therefore, the aims of the present thesis is I can easily divide it to two parts. Part one, I investigated factors contributing to intraplaque hemorrhage. In chapter 3, I investigated the relationship between thin or ruptured fibrous cap and intraplaque hemorrhage. In chapter 4, I did the same, but this time the relation between blood thinner, such as antiplatelet or aspirin, it's a very famous medication, and intraplaque hemorrhage. While in part 2, I also did two experiments to facilitate the clinical application of this imaging. So in chapter 5, I determined the diagnostic accuracy of identifying intraplaque hemorrhage by using routine MRA. MRA is different than MRI. MRA is a technique to image the blood flow, not the tissue. And in chapter 6, I also did an experiment to quantify carotid plaque composition on a fast, novel MR technique. It's called MATCH. So first, intraplaque hemorrhage. Until now, we don't know exactly how the intraplaque hemorrhage occurs. So there is many hypotheses. One of them that it comes from the new vessels because of the rupture of these new vessels, for example. Other hypothesis, it said that the blood coming from the lumen and enter inside the plaque because of the thin or ruptured fibrous cap or the ulceration. So in chapter 3, I did longitudinal study, which means that I investigate the relationship between thin or ruptured fibrous cap during time. So if I have a good relation with somebody now here, it's good at the moment, but maybe after 2 years, what happened to this relation? So exactly, the relation now between the thin or ruptured fibrous cap at baseline, it's different when what happened after 2 years follow-up. So I hypothesized that in patients with thin or ruptured fibrous cap, the volume of intraplaque hemorrhage will increase. Indeed, that we showed that patients with thin or ruptured fibrous cap, they have higher risk of developing increasing of intraplaque hemorrhage after 2 years follow-up. In chapter 4, I did the same, but this time with the blood thinner, as I said, as aspirin. Also, I did this relationship over time, after 2 years follow-up. What we shown actually that although there is increased number of new intraplaque hemorrhage in a patient who started using antiplatelet, but this, it's not significant difference with the patient who continued using antiplatelet during the 2 years follow-up. In part 2, I did experiment to facilitate the clinical application. As I said, if we want to study the plaque composition, we need multiple MR images. This is need long scan time, and it's not yet part from the routine assessment of carotid narrowing. Therefore, in chapter 5, I test the diagnostic accuracy of identifying intraplaque hemorrhage on the routine. Routine means that if somebody has a carotid stenosis, we do this investigation in the hospitals. So now, as we can see here, these two techniques, contrast-enhanced MRA or the time of flight, which is also a kind of MRA, used to assess the degree of stenosis. My hypothesis was if we can use this image also to visualize intraplaque hemorrhage. So by using the mask images of contrast-enhanced MRA, mask images that mean the source image of the contrast-enhanced MRA, I was able to identify 17 cases out of 21, which is 81%. On the time of flight, which is another technique of MRA, I was able to detect 10 out of 20, 50%. So therefore, mask images of contrast-enhanced MRA, but not time of flight, are well suited to detect intraplaque hemorrhage. In chapter 6, the quantification of carotid plaque hemorrhage needs usually multiple imaging, which needs long scan time. with the development, with the MRI, they develop match image that can acquire at the same time 3 different images in only 5 minutes. So we were able to detect these features on this novel MRI. And the benefit is that the scan time, 7 minutes in match, while 40 minutes in the conventional protocol. And we were able to detect 9 out of 10 of intraplaque hemorrhage, 9 out of 12 with the lipid, and 24 out of 32 for the calcification. Therefore, this acquisition, which need only 5 times to acquire this, is well suited to detect features of vulnerable plaque. As a conclusion, thin or rupture fibrous cap is a strong predictor of an increase in intraplaque hemorrhage volume after 2 years. Also, using intraplaque, antiplatelet as blood thinner after ischemic event does not increase the prevalence of a newly developed intraplaque hemorrhage after 2 years follow-up. Detecting intraplaque hemorrhage is feasible in the routine MRA, offering opportunities for personalized treatment strategy. And the development of easily applicable carotid MR techniques, such as match, pave the road toward the clinical application. Thank you for your attention, and I will give the word to the prorector.
Thank you for your presentation. The opposition will be opened by Professor Sluimer, Professor of Cardiovascular Pathophysiology. Professor Sluimer was also the chair of the assessment committee. Professor Sluimer.
Thank you, Pro-Rector. Thank you, dear candidate, for this beautiful summary of your work. Congratulations on this great thesis. It was a pleasure to read all of it. And I also have to say congratulations on the cover, which really nicely illustrates not only your topic of research, but also your life's journey. And I congratulate you for being here today with your family. Such a great honor to be part of that. And also, of course, my congratulations also to the promotion team sitting here today. But all that said, we are here with a job to test you a little bit and see if you can convince us a little bit more about the content of your thesis than you've already done on paper. So first of all, I would like to start with you about the match study. And you developed here a very interesting method to quantify 2 plaque components. And you propose this could be the start of the standard therapy, maybe one day that you propose in Proposition 8. So are you aware of other plaque components that can be imaged, not only with MRI, but could also serve to identify risk for patients?
Yes. Thank you, Professor Sluimer, for your congratulations, and thank you for the question. Indeed, there is multiple plaque features can be detected or can be studied, not only in MRI, but also in other imaging modalities or other techniques. So MRI is important because can visualize soft tissues within the plaque, such as intraplaque hemorrhage, lipid, etc. However, there is other factors or other features, such as inflammation. Inflammation, which is, we know the atherosclerosis is inflammatory disease. So all these features, all what is happening within the carotid plaque is because of the inflammation. MRI is not the perfect technique to study inflammation, for example. However, there is some supermagnetic, for example, particles can be used to detect inflammation. But if you ask me about my opinion to study inflammation as an important factor in atherosclerotic plaque, I would say PET, positron emission tomography. The problem with PET is, first of all, the resolution. We are talking about 2-3 millimeter plaque. And the resolution of PET, it's not that perfect to visualize this. This is one factor. The other factor is, until now, there is no, let's say, specific radio tracer can study inflammation. The most usable tracer is the FDG, which can be absorbed in any active tissue. So there is many research now is worldwide. They are investigating radio tracer to study inflammation such as choline, for example, one of the research we are doing also here in Maastricht, to see if this tracer can be used to detect or to study inflammation, which is very important risk factor in atherosclerosis.
Okay, so I see that you're well aware. That's actually very good. So that makes my life a little bit easier. So the next question is that also the vascular biologists are not stopping their research, right? And we've always thought that plaque rupture is well, first people thought it was stenosis. Now we all know it's not stenosis. It's plaque rupture and possibly intraplaque hemorrhage that predict the risk of stroke. But in other studies, namely from the group in Utrecht, the Athro Express, they show that with statin therapy targeting the inflammation, actually plaque rupture and intraplaque hemorrhage are becoming less important. So are you aware of the changes in plaque composition in those over time? If the cohort with statins and without statins, and can you think of any other imaging tools to actually quantify those changes in composition?
Yes, of course, because we are using non-invasive imaging. This is one of the strongest point of non-invasive imaging to study the longitudinal change over time. And as you mentioned, statins, it's very important. Drug can be used to stabilize the plaque. Mm-hmm. Because statin, in addition to used to lowering the cholesterol, the LDL, but also there is some anti-inflammatory specification with the statins. Atorvastatin, simvastatin, this kind of statins can be used actually to reduce the inflammation. And as you mentioned, also statins has also effect on the reducing the volume of some plaque features such as the lipid and also the intraplaque hemorrhage. I would say because now in the medical practice, when patient has a stroke, they prescribe to those patients. Usually, in most cases, they prescribe statins, which has let's say good effect on the plaque for time. So yes, indeed, we can use imaging modality to study the longitudinal change over time using different imaging modality.
But you can't use inflammation anymore or your nice tools for intraplaque hemorrhage because they seemingly, in a certain group of the patients, not all of them, of course, it becomes less important. So what other plaque components do you think you can target with imaging? Are there any developments to actually image those, or how would you develop something to image another plaque component than inflammation or lipid-rich notochord or intraplaque hemorrhage?
Do you mean other plaque features, other plaque composition can be imaged? Mm-hmm. Okay, so yeah, I said inflammation, calcification also one of the factors. However, the calcification, the macro calcification, it says that also it's good effect on the plaque stability, but the micro calcification can be also a risk factor for plaque rupture over time. Ulceration also and features can be used can be studied using, for example, CT scan. CT scan is very important also imaging modality to study ulceration. And ulceration, it's one of the factors that in many prediction models, they put ulceration to predict the risk of stroke. So ulceration features on CT scan and also calcification on CT scan. The thickness of the plaque in general, the volume of the plaque in general, and the intima media thickness also is important to be studied on ultrasound. So we have different imaging modality, and each of these imaging can be used to study one of the plaque composition. But for intraplaque hemorrhage, lipid, we would say MRI is one of the best techniques.
And then we also know that not only plaque composition changes whether or not you treat patients with the statins, but they are different between men and women, especially premenopausal, but also postmenopausal. So so which of those differences in components would you address and why?
You mean the differences between
men and women?
Sex. Okay. So we showed in one of the paper that I published, there is higher risk in men to have ruptured plaque comparing with women. And also, but there is no differences between men and women actually in the presence of intraplaque hemorrhage of the lipid. I am not aware if there is any differences between men and women in other plaque features. I didn't investigate that in my research the last 4 years.
I think you showed me quite a considerable amount of knowledge about all the different things you can measure, so I thank you for your answer.
Thank you, Professor Slimer. The opposition will be continued by Professor Saba, Professor of Radiology of the University of Cagliari in Italy. Professor Saba is online with us.
Thank you very much. Thank you, Rector. Thank you, candidate, Dr. Kassem. I would like to extend my congratulations on the doctoral thesis you have done, which addresses a topic I consider to be of absolute interest due to its potential in terms of diagnostic and therapeutical implication. I have different questions in my mind, in particular related to the chapter 4, the association between antiplatelet therapy and changes in intraplaque hemorrhage in patients with mild to moderate symptomatic carotid stenosis. You have published this paper in November 2023, so 1 month ago. And the first one is related to the time dependency of atherosclerosis development and the plaque remodeling. In your study, you have said that no significant changes in intraplaque hemorrhage are occur over 2 years. Could this lack of change be attributed to the time-dependent nature of atherosclerosis development of plaque remodeling? Is it possible that a longer period is required to observe more pronounced changes in intraplaque hemorrhage? What is your opinion? Is 2 years an enough window to study this phenomenon?
Yes, dear Professor Saba, thank you so much for your congratulations. And if I understand your question correctly, you are asking about the period of time, if this period is sufficient to show a real change in the volume of IPH in chapter 4. Yes.
Yeah.
Indeed, I do agree with you 100% that 2 years maybe is not sufficient period to detect the change. However, when we showed an association at the baseline between using antiplatelet and the presence of intraplaque hemorrhage, the median period of those patients who use antiplatelet before the index event was 6 years. And the range between 1 to 24 years. So patients use antiplatelet between 1 to 24 years. Then in order to show this association between antiplatelet and the presence of intraplaque hemorrhage at baseline. This is one important, let's say, remark here. So 2 years is not sufficient. Another factor play a role here. We are comparing actually between a group who start using antiplatelet and group who were using antiplatelet and then continued using. So at the end, after 2 years follow-up, both groups were using antiplatelet. So if we don't see a differentiation or a significant difference between two groups, because at the end, after 2 years follow-up, all patients using antiplatelet, we don't have a group after 2 years follow-up, they didn't use antiplatelet because according to the guideline, when you have a patient, a symptomatic patient, and there is no contraindication for antiplatelet, you should prescribe antiplatelet in order to prevent secondary stroke. So that's why when we showed that the new IPH 14% in the new antiplatelet user, comparing with 9% with the continued user, 14 versus 9 maybe not significant difference. But now if I compare 14% with the group who didn't use antiplatelet, maybe 1%. So 14 versus 1% would be significant difference. But unfortunately, we don't have this group according to the design of the study. The third factor, I imagine that may play a role also. Those patients, they are symptomatic patients. So all of them, they are using optimized medical treatment, statin. So maybe this treatment, or for example, also ARBs, angiotensin receptors in blockers, has effect also in the, on the atherosclerosis. Maybe this medication played a role that not showing the new or the increasing volume of intraplaque hemorrhage over time, because the effect of aspirin maybe can be compensated by the effect of the statin. So as a conclusion, I would say 2 years not enough, but I suggest to make a new research that we can investigate this relationship with the new starter of antiplatelet versus asymptomatic patient who didn't use aspirin during the follow-up period.
Thank you. Very, very interesting, and I agree. Always related to the same paper, another very intriguing point is that you find that most of patients that had intraplaque hemorrhage remain unchanging, indicating a chronic phase of intraplaque hemorrhage. Those patients had the signal of intraplaque hemorrhage for years. In this subgroup of patients where you have intraplaque hemorrhage in the baseline and the intraplaque hemorrhage after 2 years, did any new cases of cerebrovascular events occur? So in the patients with a stable intraplaque hemorrhage, there is an association with new occurrence of cerebrovascular events. What is the data? Because I think it's also an interesting point I would like to develop.
Yeah, okay. I'm sorry, I will rephrase the question because the voice is not clear enough, so that's to show that I understand the question correct.
Okay.
So you ask if there is in those patients who showed increasing volume or progression in intraplaque hemorrhage, if they do have more cerebrovascular event, right?
Or new cerebrovascular events. In the cohort of patients with intraplaque hemorrhage at the baseline and in the follow-up, did the new cerebrovascular events occur?
Yes, okay. In this study, actually, I didn't look to the vascular events in this group of patients. However, in the same group of patients in chapter 3, we looked to this information. So we showed, for example, in chapter 3 that patients who showed progression in intraplaque hemorrhage after 2 years follow-up, they are at higher risk for recurrent stroke, and the hazard ratio was almost, I think, 9.4, something like that. So in chapter 3, we showed in the supplemental result, I showed that patient who showed increasing volume of intraplaque hemorrhage, they are at higher risk of recurrent ischemic event after 2 years follow-up.
Perfect. And in those patients that there is no variation of intraplaque hemorrhage, in this case, there is an increase or it is unchanged, the rate of new cerebrovascular events?
Sorry, I didn't hear that question correctly.
In the group of patients where there is no change in terms of new intraplaque hemorrhage, there are some variations of new cerebrovascular events.
Yes, okay. So when we did this test, actually, we test the risk of progression or patient who showed regression versus no change or regression. I grouped the other patient who showed no change or regression. So I compared the progression versus no change or regression. So I didn't look specifically to the group of patients who didn't show no change in intraplaque hemorrhage over time.
Okay. Thank you. Thank you. I have a last question for you. It's my curiosity because when we study intraplaque hemorrhage, one of the challenge that we have is the definition of intraplaque hemorrhage. did you use some specific thresholds to say, okay, that one is an intraplaque hemorrhage? So not only based on the signal of the MRI, but also on the size of the signal alteration?
When we do analyze in the presence of intraplaque hemorrhage, and we quantify the volume in the MPRH sequence. So, and we define the presence of intraplaque hemorrhage is the presence of high signal intensity in the bulk of the plaque comparing to the neighboring muscle. Sometimes, if I am a doubt, I calculate the signal intensity. So usually we use I cannot say if not, we exclude, but if the signal intensity more than 2 times than the signal intensity of the neighboring muscle, I can say for sure this is intraplaque hemorrhage. If it's less and small, the volume is small, we put it, we doubt on the presence, and we ask the expert in this field to confirm if this is indeed intraplaque hemorrhage or not.
Thank you very much. Thank you.
Thank you, Professor Saba. The opposition will be continued by Professor Van Zwam, Professor of Radiology, in particular Interventional Neuroradiology. Professor Van Zwam was also member of the assessment committee. Professor Van Zwam.
Thank you, Mr. Prorector. And may I first compliment you with this beautiful and nice and concise book. Compliments go to your promotion team, Dr. Kooi and Van Oosterbrugge, who could not be here, unfortunately. And I congratulate you even more because of the background and the way you came here. And I think we should consider ourselves lucky, happy, and even proud that you are among us. Having said that, I think there's one thing I would like to know, and for that I would like to ask one of your paranymphs to read Proposition 8. Is that possible?
One day, evaluation of plaque characteristics will be part of standard clinical care, rather than solely relying on the degree of stenosis in patients with ischemic cardiovascular diseases.
Thank you very much. One day, those two words, I think 10 years ago we could have said that as well. Do you know which day that will be? I think that's the simple question. But in fact, 10 years ago already, and you mentioned a review paper that shows that this intraplaque hemorrhage has a much higher, 5 to 6 times higher chance, those patients, of a cerebrovascular event. So there is enough evidence already at that time, I would say. Do you know, by the way, how much is the risk, the increased risk in a patient with a more than 70% stenosis? Because that's still the way we decide to treat patients. Do you know that? No, that's, well, compared to the 50 to 70%, it's 2 times higher. Still, we decide to treat patients when it's more than 70%, for example, and we don't use this information that you investigated here in your studies. We don't use it in our discussions, in our decisions. So the question one day, the question is, in fact, what is needed to have these kind of studies, imaging characteristics in the guidelines? How can we include those in the recommendations? What do you think? And when is that day that we will have it?
Yes. Thank you so much, Professor Van Zwam, for your nice words. Yes, I think maybe tomorrow, maybe after 10 years. But why until now, despite the strong evidence that the presence of intraplaque hemorrhage is really a risk factor for recurrent stroke and can predict also stroke in the future? I think there is multiple things here can play a role, but I would talk only on the scientific things. There is also social, insurance things, financial things.
Why? If you have enough evidence that there's an increased risk, I mean, we do that now with measuring the stenosis grade. And we say if it's more than 70%, you have an increased risk, okay, then there's a reason to treat.
Yes.
I think the vascular surgeon knows that we decide on treatment on carotid endarterectomies based on the stenosis grade.
Yes.
Although it seems that these kind of characteristics have a much higher predictive value. So why don't we use that?
Yeah, because I think this is one of the things that I want to maybe elaborate more, because measuring the degree of narrowing is something maybe easy to measure or easy to be applicable in the clinical practice. Maybe you can use ultrasound to measure the degree of stenosis. If not, CT scan, 10 minutes CT scan, you can also do the degree of stenosis. The problem with the black features in general is we do need dedicated MR or other imaging modality to study this plaque composition. So in terms of intraplaque hemorrhage, we need to add to the protocol a new sequence, which costs another 5 minutes in the assessment of those patients.
No, you showed with your mask images that you don't even need an extra sequence.
Indeed, this is why I was happy to study the accuracy of detecting intraplaque hemorrhage on the routine MRA. Yeah. This is one thing. The second thing is there is also some, let's say, deviation between researchers worldwide. So, for example, although there is expert, they published a paper, they said, okay, MPRH as a sequence is the best imaging modality, best MR sequence to detect IPH. But still, there is still discussion between researchers that say, okay, but we can detect intraplaque hemorrhage on CT scan. Why we want to add MPRH? And some people who are interested more maybe in ultrasound, they say, okay, why you want to do CT scan if you are able to see the bleeding in ultrasound?
No,
Okay.
that's true. But if you can see the bleeding on whatever modality you use, you can use that to decide whether you should treat the patient, whether the risk is high enough. But we don't do that. We just look still at stenosis rate. I think this one day that you say as the first two words, I think that intrigues me, because one day could have been years ago, exactly what you said. It could be tomorrow, in my opinion. What do we need to have it in guidelines? You mentioned yourself we need large randomized trials.
Yes.
On page 33 it was. You said we need large randomized trials, but what kind of trial do we need then? What kind of patients should we include? What should we look at to have it in the guidelines?
Yeah, thank you for highlighting this point. It's a very important point as well. It's because we need, large randomized controlled trial to prove that the presence of intraplaque hemorrhage can be used as a risk factor. For example, we don't know yet, actually, if we have two patients with, we are not talking about a higher degree of stenosis above 70%. This group, it's clear. But we are talking about the, let's say, between 50 and 69%. So we don't know yet if those patients with intraplaque hemorrhage, if we do the surgery, will get benefit comparing with patients if we treat them only with medication.
Yeah,
so that's why we are participating here in Maastricht in the second European carotid surgery trial. That one of the aim of this trial to test if we can personalize the treatment. So patient with intraplaque hemorrhage, maybe we can do the revascularization. However, for patient without intraplaque hemorrhage, maybe we can treat them only with the optimized medical treatment. So we need to wait maybe a bit to see the results of this multi-center study. Okay. And then later need courage from the
from the experts.
Yeah, expert to put a guideline. Okay, if you want to study intraplaque hemorrhage, use MPRH or CT scan. To put a clear guideline and clear elaboration how you can delineate intraplaque hemorrhage, because not everyone can do that.
Thank you. I think the prorector wants to move on. I think it's very clear, and I trust you. If you design a new study, I think we will have it in the guidelines soon.
Thank you.
Thank you, Professor Van Swan. The opposition will be continued by Dr. Staals, Associate Professor Vascular Neurology. Professor Staals was also a member of the assessment committee. Dr. Staals.
Dear candidate, congratulations with completing your PhD project and your thesis, which was probably full of challenges. although I do understand that these are by no means comparable to the challenges you and your family had in your life. I would like to go to chapter 3, to the conclusion. You conclude on page 60 that patients with a thin or ruptured fibrous cap on MRI or disrupted plaque surface on CT are at increased risk for intraplaque hemorrhage progression. And then you conclude that these patients, so with a thin ruptured fibrous cap, may benefit from more frequent monitoring. And I was wondering, what are you suggesting to monitor? What do we have to monitor on these patients? What do you mean by we have to do more frequent monitoring?
Yes, thank you so much, Dr. Stals, and for your nice words. Yes, so those patients, they showed higher risk of IPH progression.
Mm-hmm.
So we know that intraplaque hemorrhage as a presence is a risk factor for recurrent stroke. And also the progression, the volume increasing of intraplaque hemorrhage is a risk factor for plaque progression and also therefore recurrent ischemic events. So when I stated that patient with thin or ruptured fibrous cap can get benefit from monitoring that say, okay, those group of patients, they are at higher risk for ischemic stroke. Be careful. So maybe it's better because maybe the presence of intraplaque hemorrhage will increase over time. And if the intraplaque hemorrhage increase, that means the risk of stroke is increased as well. So let's do, for example, MRI or any imaging modality every 3 months. Let's do start maybe invasive treatment with high dose of statin. Let's control the hypertension more strictly. Instead, for example, of lowering to until 130, maybe we can do it to 120.
Okay. So you mean both increased risk factor management, intensified risk factor management,
yes, exactly,
and repeated MRI scan to monitor the hemorrhage progression.
Yes.
But are there any interventions that can prevent intraplaque hemorrhage? Do we already know?
As we said during this session, that some medication, it has additional effect on the maybe decreasing the volume, but to my knowledge, there is no medication developed until now specifically to treat the intraplaque hemorrhage or to prevent the occurrence of intraplaque hemorrhage.
And all your patients were on antiplatelets, statins,
yes,
antihypertensives?
If they are symptomatic, if they are symptomatic patients, most of them, if they have, for example, high LDL, they will be prescribed statin. If they do have hypertension, you will use antihypertensive drugs. So according to the also medical history of the patients, but maybe those patients, when we showed this is thin or ruptured fibrous cap, the risk factor to recurrent stroke is higher than the thick. Maybe here also the revascularization can be an option also to remove the plaque, even if the degree of stenosis is less than 70%. So what I would say, those patients, this high-risk patients, even the degree of stenosis is less than 70%, decide what you want to do as a therapist. Treat with the medication or do the operation.
So we don't need a trial. We just have to do surgery on those.
But this is one single study, one single center study. So maybe if this proved in other studies, it's.
Hey, and another question, because you just said maybe we could do an MRI scan every 3 months. Do we know anything about the intraplaque hemorrhage? Does it occur gradually or all of a sudden?
I don't know, because when we image this, we see a specific time. It's not like ultrasound. You can monitor this patient maybe every day or every week to see, okay, now we have 1 millimeter hemorrhage, then the next week 2 millimeters. So, but we image those patient actually in a specific time, cross-sectional time, and then after 2 years. We don't know exactly what happened between these 2 years. Maybe, because this is also part for answer for Professor Saab, because 2 years, maybe those patients who showed progression, maybe they showed regression first, then they showed progression. Yeah. We don't know what happened within these 2 years. And maybe this, okay, they have small, then it's resolved, then another hemorrhage happened in the same place after 2 years. Because we do have only baseline and after 2 years. What is going on between these 2 years? I don't know.
No, so maybe it's very interesting from a research point to scan them every 3 months, but I don't know whether that's already the thing to go in the clinical practice, because we don't know.
Yes, exactly. Yeah. This is maybe it's very important. But always when you want to design let's say a research, there is multiple factors. I wish if I have, for example, asymptomatic patients, I can monitor them for 5 years. And I wish if I can do the MRI, maybe only MPRH, it's sufficient to detect the every 3 months. Then I gather all the clinical information. Then I can say for sure what is going on within these 5 years in these asymptomatic patients. But always it's difficult to get fund for this research.
Thank you.
Thank you.
Thank you, Dr. Staals. The opposition will be continued by Professor Schuring, Professor of Vascular Surgery, Institute, Maastricht University Medical Center. Professor Schuring.
Yeah, thank you, Mr. Prorector. Dear candidate, first, my congratulations. When you brought me your thesis, you explained to me the cover a little bit more extensive than you did today. And even after reading both your experimental work and also about your life, I'm even more impressed that you're here today. So congratulations. Also, for your promotion team. The proposition 8 was already read, but perhaps you would ask the other para-nymph to read proposition 3 for me, please.
Routinely acquired mask images from CEMRA can be used to visualize IPH.
Yeah, thank you. And especially, I'm especially interested in both propositions because the word carotid is missing in both, and that is because a plaque, atherosclerotic plaque, is much more general than just the carotid artery. If, as a vascular surgeon, more patients are having intermittent claudication due to a stenosis in the superficial femoral artery, then patients have TIA or strokes. But in those patients, we never look at intraplaque hemorrhage. Should we do that? Because is that also a risk for complications, for embolic problems?
Yeah, thank you so much, Professor Schuring, for your nice wishes and nice words. And my apology for missing the word carotid in proposition 3. Atherosclerosis, I think it has the same background in all arteries, if I can say that. So if that's in different arteries, it should be the same. However, I have no idea if this atherosclerotic plaque in different arteries can also, or the mask images can be used to detect intraplaque hemorrhage on these arteries. But maybe somebody else did this research, or he showed that intraplaque hemorrhage in the femoral artery is a risk factor for pulmonary embolism, for example. I don't know.
I looked at the PubMed, and there are so no hits in intraplaque hemorrhage and femoral artery.
Yeah.
So they're just not looking at that. But probably if you have intraplaque hemorrhage, these plaques should embolize. But why? I never see the patient with clinic symptoms of that. Why is that?
Yeah, if I can interpret that, I can say, okay, although atherosclerosis is the same, but also the location of the artery are different. So there is also other factors maybe play a role in the occurrence of intraplaque hemorrhage, such as the shear stress, the wall shear stress, for example, and the bifurcation area, and type of the flow of the blood going, for example, upward or going downward, like. So maybe there is other factors can play a role, which is, okay, some researchers actually showed that there is a relationship between, for example, low shear stress and the presence of intraplaque hemorrhage. And they showed also maybe also the pathophysiology of the new vascularization is different between arteries. So the background or the mechanism that IPH is occur is complicated, and multiple factors can play a role. Therefore, maybe there is no intraplaque hemorrhage in the femoral arteries or other arteries. I'm not sure. I don't know. And if there is intraplaque hemorrhage, maybe it's not risk factor for some diseases, BAD diseases.
No, but it would be interesting to study, and perhaps it's just because most of the blood is just going to muscles, and muscles are not that sensitive to emboli as brain. Yeah. But I could imagine that that if you look at plaques in renal arteries or mesenteric arteries, where the tissue is more vulnerable, that it would be nice. And do you think, because we often make MRI studies in those patients, do you also think that the current protocols with with the contrast enhanced MRA and the mask images would be suitable to look at the intraplaque hemorrhage in those areas?
Not in the carotid artery, the other arteries, you mean?
Yeah, like in the other arteries.
Yeah, if there is intraplaque hemorrhage and the signal intensity of intraplaque hemorrhage is the same, so I think we can do that as a pilot study, maybe, to see. We can select high stenosis patients, and we do acquire the mask images for 10 patients, 20 patients, something like that, and we start looking if there is intraplaque hemorrhage or not according to the signal intensity. And if there is, then it's a really interesting question to actually study more in depth this pathophysiology. But I don't know actually if, but yes, mask images, if the signal intensity of intraplaque hemorrhage in these arteries is the same, so we should be able to detect intraplaque hemorrhage anywhere in the
so
body.
I think that would be a nice study to do. So you gave us an idea. Thank you very much for the answer. I give the word back to the pro-rector.
Thank you, Professor Schuring. The opposition will be continued by Professor Mess, Professor of Clinical Neurophysiology, Maastricht University Medical Center. Professor Mess.
Thank you. Well, dear candidates, I will ask you some questions about your thesis later on. But first of all, let me express my appreciation for what you have accomplished. And I mean much more than this book here. Of course, I knew your name. And we talked about research via Teams, but I was completely unaware of your background, I have to admit. And only when you handed me your thesis in person, which I appreciated very much, we had a short yet memorable conversation. So when I congratulate you and your team with this thesis, this is by no means an empty phrase, it's completely the opposite. Let's talk about the temporal dynamics of intraplaque hemorrhage. There is a high circadian variability when it comes to stroke incidence. Do you know when during the day the incidence is highest?
In the early morning, if I...
Yeah, that's completely right. How can this be explained by plaque morphology?
Yes, so thank you so much, Professor Mas, for your nice words. And I also enjoyed the discussion with you when I handed my thesis to you. Yes. We know that when I studied medicine, they said in the early morning there is corticosteroids, there is a lot of, in our body can be, so there is a lot of activity going on in the early morning.
Yeah.
So maybe that lead to the differentiation also in the blood pressure between the systolic and the diastolic. Maybe also the spasm of the arteries will be different. So maybe that will lead to the fragmentation of the atherosclerotic plaque.
This is already a very interesting discussion. Maybe you are aware of a review. It was published last month. They had a long list of possible factors, but plaque morphology was not within the list. So let us expand to days and a few weeks. When is the risk of a recurrent stroke after a first stroke highest? Roughly. How long does it take? What is the highest possibility to have a new stroke? What is that interval?
I think within 6 months, if I...
Much less. It's 6 days or so, some weeks, 1 or 2 weeks. Does this have clinical consequences?
Yeah, I mean, I'm not sure if I answer it. I can say, okay, those patients already, they are not stable. So if they do have recurrent stroke within 1 week, then also the pathophysiology of them is not full recovered. So would be also more complicated case to be...
that could be true, but the opposite actually is the fact. So I look to my colleague, a vascular surgeon. He will only operate on a patient within 1 or 2 weeks, because then the effect is largest. So is this change of plaque morphology reflected in the IPH characteristics? Changes within 1 or 2 weeks? Do we see that with IPH analysis?
I can say within 2 days, because we did a study, or before me, the group did study, they did the MRI within 24 hours, and they studied the volume of intraplaque hemorrhage, but the aim of that study is really different than what you are mentioning here. So they said the volume is the same between 24 hours, there is no such a differentiation, but at the end also I can say that we cannot sure if we measure, because always there is also variation between myself. If I delineate today and delineate tomorrow, maybe I will find 5% difference.
Okay, so there are some changes, there is some progression, and there is some regression, but actually it goes into all directions. And I got the impression that your temporal resolution is way too low to get a clear-cut idea how fast this is going. So the question then is, if there is so little known and if there is so little change within time, and we know that plaque revascularization occurs at least within 4 weeks, maybe even faster, and that is the reason not to operate on a patient after a month or something like that. What is then the pathophysiological mechanism of IPH? How does it contribute to a stroke? I don't understand that.
Yeah, it could be related to the inflammation, because the inflammation and the blood, the red blood cells maybe can enhance and stimulate the inflammation and the macrophages.
Okay, I have a very tempting question. Do you see an elevated risk of myocardial infarction when you have intraplaque hemorrhage in the carotid artery? Do you know that?
I don't know.
Has it ever been shown that it makes any sense to remove a plaque with an intraplaque hemorrhage and that the prognosis of the patient improves? Has that been proven?
Also, I don't know.
No. So maybe the intraplaque hemorrhage is just a sign for a process in the body, and it would be a sin to remove the plaque because it gives us very valuable information. Is that total nonsense?
Yeah,
Mohamed Kassem, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return to this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and that. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Yasmin is not here yet. Oh.
Mohamed Kassem. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Kooi is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. Kooi.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Mohamed Kassem, the degree of doctor and grant you all the rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dear Dr. Kassem, dear Mohamed, it is a great pleasure to congratulate you with your doctorate. My congratulations are also on behalf of your second promoter, Robert van Oosterbrugge, who unfortunately cannot be here today. I also extend my congratulations to your family, particularly to Jasmine, your mother, Julia, Akat, and Inanna, who played a crucial role in supporting you throughout this journey. We first met during the first course of the imaging specialization in the Master Biomedical Sciences. Because you were unable to pursue your career as a neurosurgeon in the Netherlands, you redirected your focus towards scientific research. You stood out as an enthusiastic and dedicated student. Therefore, I did not hesitate to offer you an internship for your master research project when you contacted me. You successfully applied for a prestigious grant from NWO, the Hestia grant, to continue research after completing your master degree. A second personal research grant from CARIM, the HS BAFTA grant, provided the opportunity to perform a PhD project. It is really a great pleasure to work with you. You are always smiling and ready to help others. In the face of life's challenges, you are an inspiration for many by not giving up and staying positive. This has not gone unnoticed, and you became our superstar and received recognition on television and in newspapers. A highlight was when we were invited to present your research at a prestigious event, the Evening of Science and Society, in the Ridderzaal, next to the throne in the presence of King Willem-Alexander. A few years ago, you also became a Dutch citizen. Although it is extremely sad that you had to leave your homeland, we are privileged in the Netherlands to have you among us. As a true family man, you combined your PhD research and taking care of your family. Your family was extended with the birth of Akkad and Inanna during your master and PhD research, juggling the responsibilities of parenthood. With academic research, you successfully submitted papers amid late-night feedings and showing your dedication. Your research provides more insights in the factors that contribute to plaque destabilization and, ultimately, stroke. It is also an important step towards clinical translation of plaque MR imaging. Your work is well recognized by your peers, and you received several awards, including the Best Poster Presentation at the ESOC conference, and also the Best Abstract at the Ville Rouge Congress, which underscores the high quality of your work. Beyond your academic achievements, you also demonstrated a commitment to present your work to the general public. For instance, through presentations at the PAS Festival, the Pleasure of Arts and Sciences. You are currently continuing your research as a postdoctoral fellow with the second personal Karim Haas BAFTA grant in the High Field MRI Center in Jülich. We miss your warm personality and your expertise in Maastricht. I have full confidence in your continued success in the future. I am looking so much forward to hear more about your future adventures. I wish you a lot of happiness and success for the future.
Thank you so much. Dear Dr. Kassem, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I wish you a great future as an academic and in your life. And hereby I close this academic ceremony.
Recording stopped.
You can congratulate the candidate, the new doctor. I would like to ask the family to remain, and we will make a picture here also together with